Good afternoon, everyone, and welcome to this public webinar on tapering guidance for opioids, existing best practices, and evidence standards. My name is Elizabeth Finkelman, and I direct the National Academy of Medicine's Action Collaborative on Countering the U.S. Opioid Epidemic, which organized this webinar. The Action Collaborative is a public-private partnership of 60 members from the public, private, and nonprofit sectors, all committed to developing, curating, and disseminating multi-sector solutions designed to reduce opioid misuse and improve outcomes for individuals, families, and communities affected by the opioid crisis. On behalf of the Action Collaborative and the National Academy of Medicine, thank you for taking time out of your day to join us for this important session. Next slide, please. Today's webinar will last 90 minutes and will follow the agenda you see on your screens. We will begin with a 5-minute overview of the topic and panel to be given by our moderator, Dr. Roger Chow from Oregon Health and Science University. Dr. Chow will then introduce our 5 panelists who will each present for 10 minutes. We will then move into a 20-minute moderated discussion with the panel before opening it up to questions from the webinar audience. Next slide. Questions and comments from the webinar audience can be submitted at any point during the webinar, and we will do our best to get to as many of them as we can before the webinar concludes. You can submit questions via the Q&A box located along the bottom of your screen. Simply type your question in the box at any time and click send. This webinar is being recorded, so please understand that any questions you submit may be read aloud and included in our recording. Next slide, please. We hope you will join the conversation on social media and tweet over the course of the webinar by using #OpioidCollaborative. Next slide. And finally, I want to conclude by acknowledging and thanking the sponsors of the Action Collaborative who make our work possible. And with that, I will turn it over to Dr. Roger Chow to get us started. Thank you.
Thanks, Liz. I'm Roger Chow. I'm at Oregon Health and Science University. I'm an internal medicine primary care physician, and I do research and work in opioids, acute and chronic pain, and addiction. Thank you for joining this webinar. Tapering is a very important issue that impacts clinicians and most importantly impacts patients. The purpose of this webinar is to discuss different perspectives and evidence on tapering. I'm excited to introduce the panel who will be talking about tapering from a variety of perspectives, including the acute postoperative perspective, managing patients on chronic opioids, a patient caregiver perspective, as well as some health policy considerations. The panel members are Chad Brahmin, who's an associate professor of anesthesiology at University of Michigan, Aaron Krebs, professor of medicine at the Minneapolis Veterans Affairs Healthcare System. We have Anna Lemke, who's an associate professor of psychiatry and behavioral sciences at Stanford University. Ann Burns, the vice president of professional affairs at the American Pharmacists Association. And Kate Nicholson, co-chair of the Chronic Pain Opioids Task Force for the National Centers on Independent Living. With that, I'd like to hand over the presentation for Chad Brahmin, who will be discussing tapering in the context of postoperative cases.
Thanks, Roger. Can I get the next slide? I'm Chad Brahmin. I'm an associate professor of anesthesiology, and I'm also a pain physician at the University of Michigan. I'm also one of the co-directors of the Michigan Opioid Prescribing Engagement Network, or Michigan Open. Next slide, please. So I'm going to present a case that's related to surgery. This is a 48-year-old woman who presents for an evaluation for a laparoscopic hysterectomy for uterine fibroids. Her past medical history is significant for low back pain, depression, anxiety, gastroesophageal reflux disease, and tobacco dependence. Her home medications currently include citalopram for depression and alprazolam as needed. Her social history is significant for alcohol and is not significant for any alcohol or illicit drug use. In her family history, she reports chronic pain and a deceased father with a history of alcoholism. Next slide, please. For preoperative management, she was given a prescription of 30 tablets of 5 milligram hydrocodone with acetaminophen in her pre-op visit about 7 days before surgery. Her surgery was relatively uneventful. She went through a laparoscopic hysterectomy under general anesthesia. They used local anesthetic at the port sites, as well as post-operative intravenous and oral opioids during her brief inpatient stay, and she was given scheduled acetaminophen during that time as well. At discharge, the next day, post-operative day 1, she notes to the discharging physician that she used about half of the hydrocodone she was given preoperatively during the preoperative period about that week. She's prescribed an additional 60 tablets of 5 milligram hydrocodone at that time and told to use acetaminophen and ibuprofen regularly for the first 3 days. Next slide, please. 2 weeks after surgery, she calls for another refill of her hydrocodone, and she's prescribed an additional 45 tablets. She calls again 5 weeks after her surgery, requesting a refill again. However, the surgeon who is covering for her normal surgeon denies that refill. She then seeks care in the ER multiple times over the coming weeks and is administered intravenous opioids during those visits and given opioids at discharge, at least a couple prescriptions of 30 tablets of 5 milligram hydrocodone, and told to follow up with her primary care physician. Next slide, please. So what we present is a patient who was not using opioids before surgery, but who has chronic pain, who became what we might call a new persistent opioid user or a new chronic opioid user. Most patients after a laparoscopic hysterectomy would be expected to use opioids, although not all. And what we know is that not only for something like a hysterectomy, but effectively most of the conditions that our group has studied, we see some rate of what we would call new persistent or new chronic opioid use. And another way to put it would be that becoming a new chronic opioid user could very well be considered the most common complication after elective surgery. And we do consider it a complication mainly because the intent of that initial opioid prescription is for post-surgical pain, not for chronic pain management. Moreover, we don't really see that this is being specifically about post-surgical pain, which our group does study. The evidence for that top reference there, the JAMA surgery reference, we found that about 6% of patients undergoing both major and minor surgical conditions became new persistent users, and there was no difference between really big surgeries and surgeries that would be considered very minor. That second reference also notes about 8% of total knee replacement patients becoming new persistent users, and when we prospectively followed patients up after surgery, there was no association between whether or not their knee got better, worse, or stayed the same, and that likelihood of new persistence. Next slide, please. So what is happening here? Well, we do know that there are patient factors that have been consistently shown to be associated with this new persistent use, specifically anxiety and mood disorders, preoperative sleeping problems, and history of opioid use in the past, even among those people who are not using opioids. On the right side, you see things like chronic pain conditions, histories of substance use disorder, and tobacco use. And yet, we treat all of these with chronic opioids post-surgically, and we do believe these are some of the factors that predispose patients to new persistent or new chronic use. Next slide, please. The way we prescribe also matters. Our group and other groups like Mark Pickett's group at Johns Hopkins have shown that the increased amount of opioid you prescribe leads to increased consumption without any changes in pain, satisfaction, or refill requests. So if you get more prescriptions, you'll actually use more opioid without any improvement in post-surgical pain satisfaction or the need for refills. Moreover, preoperative opioid prescribing can increase your risk of refill and new chronic use. So as in this case where the patient receives an opioid preoperatively as sort of a convenience, if you will, that getting that prescription is associated with higher rates of new chronic use, as well as high prescribing. Those patients that get prescriptions that are in the higher quartile or decile, that top 10 to 25%, also have new rates of chronic opioid use. And this has also been seen in emergency medicine as well. Next slide, please. We know that opioids are effective for severe acute post-surgical pain, and we do believe that they have a role for post-surgical pain. However, we also know that many surgeons and dentists have started prescribing more opioid and giving doses to more people for concerns of satisfaction and also concerns about refill requests, especially since hydrocodone since the policy changes that preclude physicians from simply phoning in a hydrocodone prescription, which is Vicodin and Norco. We know that that has led to at least some of the increase in prescribing after surgery and dentistry. And yet, there is no association between the number of pills prescribed and patient satisfaction with their care or their refill requests. Refill requests do come, they do happen, but prescribing more doesn't decrease that likelihood. Moreover, satisfaction isn't driven by opioid prescriptions. Certainly there are patients that will report being dissatisfied by the amount of opioid they prescribe, but at a data level, where we actually look at the data, this is not the factor that's driving satisfaction. Instead, we think that treating patients like customers and actually attending their needs and being attentive to them is far more important. Next slide, please. Our group has made prescribing recommendations for a number of surgical conditions. I won't leave them up there for too long. They are available on our website. They're based on real patient data as well as other publications from other groups. And we also update these on a regular basis. This is the third iteration. And you'll see we put a range in there from 0 to a number. And the reason we do that is we see a sizable portion of patients, even after significant surgeries like knee and hip replacement, about 30% of patients after a hip replacement and about 19% of patients after a knee replacement use no opioid after leaving the hospital. And we believe that you need to start to tailor that care. However, we do sort of put up a high number that we would recommend for patients not using opioids before surgery. Next slide, please. We think that the real key here is that surgeons educate patients and set expectations. We also encourage patients to use acetaminophen and ibuprofen on a regular basis. While I know there's concerns about both of these medications, when taken as directed on the back of the bottle for a short period of stay, the vast majority of patients can use these medications. Local anesthetic can also decrease acute pain. We are concerned about the use of benzodiazepines and opioids together because they increase overdose risk and would be very careful there. Also encourage providers to check a prescription drug monitoring program. There's certainly PDMPs have been made controversial, but honestly, this is just an opportunity to have a sense of what patients have been using, not as a way to hold back from patients. Next slide, please. For providers who are prescribing, we encourage only one short-acting opioid, and this is for opioid-naive patients. Don't give multiple types of opioids. Don't use long-acting opioids in a patient who wasn't using opioids beforehand. I would suggest that we avoid the preoperative prescription of convenience as was given in this case. And in patients with high risk, we really need to be thinking about naloxone. Next slide, please. I think that where this leads into today and the reason we were invited to present today is that withdrawal happens. For patients who take opioids for even more than a couple days, you can start to become tolerant, and if you acutely stop, you can withdraw. And we certainly have heard stories. Travis Ryder tells a very compelling story about his own experience with surgical withdrawal. And in the case, next slide, please, where a patient's been on it for a few days, you do need to make a tapering schedule. And there are groups out there, Ed Mariano and the group at the VA have done some really nice work in creating tapering schedules. Next slide, please. And so what was the case resolution here? The patient went back to her primary care physician about 10 weeks after surgery, notes that she was taking about 4 to 6 oxycodone per day and acknowledges withdrawal symptoms between doses. She, when asked, says that the main reason that she's using the opioids at this point is for her preoperative pelvic pain and low back pain, and that the incisional pain is long resolved. And we know from our next speaker, Dr. Krebs, that there is little evidence that opioids are effective in most patients for chronic pain. So a slow taper is written by her primary care physician, and she successfully weaned several weeks later. She was then referred to pain management for management of her preoperative chronic low back pain and chronic pelvic pain. Next slide, please. So if you'd like to learn more about our work, find our prescribing recs or our patient materials, please go to michigan-open.org. And with that, I will hand over to my colleague, Dr. Erin Krebs.
Hello. I have the assignment of simple legacy cases, although I don't know if any tapering case is truly simple. I practice in primary care, and this is a primary care case. Next slide. I think this is a common scenario, a new patient coming to primary care clinic seeking a new physician after, in this case, his primary has retired. So this is a 60-year-old man, and his chief complaint is, I need my pain medications refilled. He has about a week left of his medicines. His problem list includes chronic back pain on opioids for more than 15 years, depression, anxiety, and a number of medical problems. His medications include morphine, sustained release, 60 milligrams 3 times a day, oxycodone with acetaminophen, 8 tablets a day, as well as clonazepam prescribed by his psychiatrist. He reports no alcohol, illicit drugs, or opioid use problems. And when you review the chart, you see, that the chart review, prescription drug monitoring program report, and urine drug test results are all consistent with his reports of prescribed medications. Next slide. So my initial impression when I saw this man is that this is someone whose opioids I'd like to taper. It looks like a high-risk regimen to me, but I want to do that in a patient-centered manner. So briefly to review, patient-centered care has been defined as care that is respectful of and responsive to individual patient preferences, needs, and values. And I think it's important to distinguish this from other concepts. Patient-centered care is not simply a customer service activity, give the customer what they want, nor is it an alternative to evidence-based care. Really, what patient-centered pain care and patient-centered opioid tapering does is considers the evidence of treatment's potential benefits and harms in the context of patient goals and values. Next slide. Talking about goals and values is important for a number of reasons. It helps you to get to know the patient as a person. It demonstrates you care about their individual experience, and it really provides a basis for your assessment and treatment plan and for future conversations, including and especially the more difficult conversations that might happen around opioids. So goals in particular, I think, are really important to talk about at this first visit with this new patient. I think about 2 kinds of goals. The first kind is the big picture or life goals. This is really what does the person want their life look like? It should be linked to their big picture values and aspirations. These goals may not be achievable in the short term, but they are very important for grounding treatment decisions and also for generating more short-term goals. The short-term goals are linked to the big picture or life goals, but should be achievable in the short term. Often, these goals are described as being SMART, so specific, measurable, achievable, relevant, and time-bound. For example, my goal is to walk 4 blocks over the lunch hour every day, Monday through Friday, while I'm at work. Goals like this are helpful for reframing pain conversations. So we have this tendency now to talk only about how bad you hurt and not to talk about what you're doing. So I think the reframing part of this is really important. And they can be helpful for just promoting and focusing on behavioral change and self-management. Next slide. A very consistent finding in the literature is that patients really do want us to ask and talk about how pain affects their life, not just about, how bad the pain is. And, we are often really seeking to understand how pain is affecting functioning, but you can't just ask a patient about their functioning. So these are some of the valuable questions I like to ask, especially, how would your life be different if your pain was well controlled? Next slide. You ask all those questions of this new patient to your office. This is some of what you learn. So this is our 60-year-old man with chronic back pain. When I talked to him, I found that his big values were he was a family man. He really valued his independence and being seen as a reliable go-to person for the loved ones in his life. In contrast, his current reality is that most of his days are spent in bed. Pain was preventing him from participating in valued activities to the extent that he was not even trusted to be alone with his grandchildren because he might nod off or fail to pay attention. He was unable to go to important family events and really hadn't been able to travel for a number of years. He perceived that opioids were effective, but drilling down on it, really they just took the edge off his pain. Nonetheless, he said they were really the only way he could function. He couldn't imagine living without them. We were able to talk about some big picture goals, and those included being a more involved grandparent, traveling, and again, being able to take care of house and family. Next slide. So when talking about tapering with this person, he does not want to taper opioids, and I do. So it's going to be really important for me to provide an individualized rationale for him. I need to get on the same page with him. We know some things from research about this. We know that clinicians tend to focus on overdose, death, and addiction risk, whereas patients often may fear uncontrolled pain or suffering more. Most patients seem to perceive their personal risk of overdose as low, and so it's not going to be helpful for us to focus primarily on that. On the other hand, most patients do have priorities for pain treatment beyond simple pain relief, and those are the priorities we should elicit and focus on. When thinking about tapering, we also need to elicit and address concerns about why someone may not be interested in changing their opioid regimen, worries about uncontrolled pain, withdrawal, abandonment by clinicians, and loss of control over health care. And we need to involve patients in developing a tapering plan. Next slide. This means talking about shared decision-making with patients. I think the concept can be simplified down to 3 steps. It's sharing information both ways, deliberating about options, and agreeing on a course of action. This may be as simple as the next step. It doesn't have to be agreeing on everything right up front. Importantly, shared decision-making does not require the prescribing physician to give up decision authority. So you don't have to put every single decision on the table. It's simply a matter of including the patient as much as possible. Next slide. This slide just illustrates the degree of decision sharing, that it is a continuum, and rarely are decisions perfectly equally shared. Next, we often forget that patients are the ones who typically, who most often make a decision to discontinue opioids. This is animated. Can you hit the next slide? There we go. So an example of this is when patients experience severe adverse effects of opioids, they often just stop the medicines and we find out about it later. Next. All the way on the other end of things, sometimes we just simply have to make a unilateral decision. An example here is if drug testing was showing cocaine and not prescribed opioids, and you're confident in making a diagnosis of diversion and substance use disorder in a patient who you don't believe is even taking the medication, well, you probably don't really need to share decision-making about tapering at that point. For most patients, though, decisions are somewhere in between unilateral patient and unilateral prescriber. Next. For this patient, this is my assessment. I would really walk through this with the patient to explain my thought process. My assessment is there's no apparent benefit from therapy despite high-dose opioids. Severe pain is interfering with function and participation. The patient has multiple risk factors for serious harm, but at the same time, there is no evidence of impending overdose and no evidence of misuse, so no huge urgency here. In terms of adverse effects, there are likely a number of symptoms and conditions that opioids are making worse, including sleep apnea, fatigue, amotivation, and depression. So my plan in this case was a non-urgent, doctor-led, patient-involved tapering approach. Next slide. I think it's important to be clear with the patient, so I would say to him that I think we need to make changes in your medication. But then I would really want to do some more talking. In this patient case, we had several visits before he agreed to a first dose decrease. This slide just shows some of the questions I would ask to elicit his concerns and get him involved in the process. Asking what the concerns are about reducing pain medications is really important, just so you can get those things out there. The last three questions on this slide are really about the deliberation part of shared decision making. I may not give them a choice, do you ever want to reduce your dose, but I will talk a lot about the different options in terms of how we can do this. Next slide. And this is what happened with this case. This man was able to taper his opioids to a lower daily dose, but it took quite a bit of time. So over about the course of 2 years, we tapered the morphine off. And I went down slowly on this, just one 15-milligram tablet at a time, alternating with reductions in oxycodone. Eventually, we reduced the oxycodone to 3 tablets a day, but continued at that level. And the patient has continued clonazepam with his psychiatrist. In terms of his pain, it really did not change during this process, but his ability to cope with the pain and manage it and live with it has gotten much better. And he had dramatically improved physical and social function over the course of a couple of years. He did have a trouble in the middle with increase in PTSD symptoms. We just paused the taper, got help for that before resuming. Next slide. I put a couple alternative case resolution scenarios here just because things can go in different directions and unexpected directions. I've had patients taper very rapidly and do very well, even with dramatic improvement in pain. I've also had patients who really have trouble and hit a wall early during tapering. I'm going to make a transition right now to our next speaker, Anna Lemke, because she'll talk some more about some of the reasons why tapering can go sideways.
Thank you, Erin. So I'm going to focus on how to talk to patients about opioid tapering and guide them through that process using sort of a structured framework that we've developed called the Bravo protocol. Next slide, please. This is my disclosure. I've been retained as an expert witness on the plaintiff's side in federal and state opioid litigation. Next slide. What I'm going to talk about today is also found in this free online CME course, how to taper patients off of chronic opioid therapy. Next slide, please. And much of what is included in my section today can also be found at the Oregon Pain Guidance website on opioid tapering. Next slide. So the Bravo protocol is basically an acronym just to sort of help guide a biopsychosocial framework for opioid tapering. B stands for broaching the subject. And the main message here is just to remember that for many patients with chronic pain who have been on opioids long-term, even just bringing up the subject of an opioid taper is extremely anxiety-provoking. Next slide. So it's really important to take more time, and if you work with a team, to get support for the team from the team and really think through, the decision making before you go in, and again, importantly, to schedule more time. So this is a case. Sherry, at age 18, she developed pain in her abdomen. It spread through her whole body. Medical workup was negative. She saw lots of doctors over a period of time, was ultimately diagnosed with fibromyalgia, prescribed opioids, and by age 30, she was taking approximately 800 morphine milligram equivalents daily. She said that the doctor was, quote, the most compassionate doctor I ever saw. The reason I include that is just to emphasize that for a long time, we did equate compassion with opioid prescribing. So one of the things that I will emphasize in how to talk to patients is how to remain in a compassionate stance, even when we make the decision as the healthcare provider that the patient needs it to be tapered down on their opioids, especially when the patient doesn't necessarily agree. And by the way, she had always taken her opioids as prescribed. There was no suggestion of an opioid misuse or opioid addiction problem. Next slide. Just to emphasize that despite her high morphine equivalents, she did not have improved pain. Her function was worse. She spent more time in bed, and her husband remarked that she was detached from family life. Okay, next slide. So when broaching the subject with patients, it's just really important to emphasize that this is not something that you're doing in retaliation or impulsively, but that you've really been thinking a lot about the patient and their chronic pain. It's important to use kind of gentle and suggestive language. I like to suggest that we taper you down and maybe even off your opioids. And it's also important to anticipate the fear of the patient. By just simply saying, validating that experience. I know the very thought of an opioid taper is terrifying, but you're not alone in that. It's normal to be afraid about going down on your dose. But let me explain the reasons why I think this is a good plan for you. Next slide. It's also very important when you're broaching the subject. I think, especially when you're thinking about the inherited patient, somebody who comes to you already on high doses. What we're seeing now is a lot of docs refusing to take these patients or immediately beginning the taper on the very first visit. I would recommend that you not do that. It's frightening for the patient to have to think about an opioid taper the first time that they meet you. And also, it's perfectly okay to wait before initiating that conversation, as long as you carefully document that you are considering risks, benefits, and alternatives. Where prescribers get into trouble legally is when they don't show evidence in their documentation of understanding the risks and monitoring the patient and engaging the patient in a careful risk-benefit assessment. So I recommend that when you inherit a high-dose patient, you just document that you're going to be broaching this subject, but you're not going to do it immediately because you want to build a good alliance with the patient so that you can optimize the chances of a successful taper. Next slide. In the risk-benefit calculator, next slide, it's just important to emphasize that first we must do no harm and say to patients, I think we need to get you off opioids because they're doing more harm than good. So in other words, we have done that assessment and decided that that's the case. And letting the patient know that that the opioids are not really working for their pain, and in some ways may even be making the pain worse through opioid-induced hyperalgesia. It's important to talk to patients about their lack of functionality, and that being one of the targets for the taper. And then finally, with patients who think that the opioids are really helping them and don't want to make the taper, it's really just, again, Dr. Krebs talked about this too, to emphasize that you came to this decision through a very deliberate and thoughtful process of medical decision making. It's not retaliatory, and that really you believe that the best thing for them is to slowly taper off the medications. Next slide. There's also, some studies emerging showing that when patients with chronic pain are tapered off of their opioid therapy, some of them do experience improvements in pain. And I often tell patients that to let them know that there's even a possibility their pain will get better when we get down to a lower dose. Next slide. The A of Bravo is addiction happens. I think it's really important to discuss the possibility that the patient might have become addicted, and also sometimes the taper itself can be a litmus test for who has become addicted. Next slide. What I'll often do is sort of own the complicity of the healthcare profession. I'll say something like, when we first started prescribing opioids more liberally in the 1980s, we believed the risk of becoming addicted was really low. But what's happening is that we're learning that even when patients with real pain take their medications as prescribed, they can get addicted. And then sometimes I'll say, so if in the process of a slow and medically supervised taper, we find that you're unable to get off opioids, maybe, it's possible that you would become addicted. There's no shame in that. You're not alone. Millions of people become addicted, and there's good treatment for opioid addiction if that's the case. Next slide. And this is just a meta-analysis by Voles et al. Showing that 1 in 4 patients with chronic pain taking medications, opioids from their doctor, will develop an opioid misuse problem, and 1 in 10 will develop a severe opioid use disorder. Next slide. It's also important to know how to diagnose opioid use disorder in the context of a patient with chronic pain on long-term opioids. Specifically, of the 11 DSM-5 criteria for opioid use disorder, tolerance and withdrawal are in those 11 criteria, but they don't count as long as the patient is taking the opioids as prescribed. So if a patient meets criteria for tolerance, needing more and more to get the same effect, or withdrawing when they go down on the dose, those don't count if the patient is taking the medication as prescribed. You have to find 2 additional ones: out of control use, compulsive use, cravings, or continued use despite consequences. Next slide. So what happened with Sherry was that at 800 morphine milligram equivalents, she didn't meet criteria for opioid use disorder. But as we attempted to slowly taper her in a patient-centered way over 18 months, it became apparent that she did have an opioid use disorder. She was unable, for example, to adhere to even minimal dose decrements. And she had very serious ongoing medical consequences as a result of the opioids. She had hypoxemia, she was fatigued and often somnolent, nodding off during meals with her family. She was depressed, she had cognitive dysfunction. So we went ahead and diagnosed opioid use disorder. Next slide. And we transitioned her to buprenorphine. She experienced improvements in mood, cognition, activity level, alertness, and breathing. Her pain did not improve on buprenorphine, but it also did not get worse. Next slide. So sublingual buprenorphine is FDA approved for the treatment of opioid use disorder. It's very important to make it clear to patients that it is an opioid, but it has unique properties that make it ideal for the treatment of opioid addiction. It has a very long half-life, which gets patients out of the cycle of intoxication and withdrawal. It has a high binding affinity, which means that once it's bound to the receptor, if patients use other opioids, they probably won't feel the effect of those other opioids. That also means that when we get patients on opioids, they have to be in active opioid withdrawal so that they don't have precipitated withdrawal. And finally, it's a really good harm reduction strategy because it has a ceiling effect on euphoria and respiratory depression, so patients are much less likely to accidentally overdose on buprenorphine. Next slide. The V of Bravo refers to velocity and validate, and this is probably the most important part of this protocol. The biggest mistake that I see with folks who are tapering patients is that they taper too quickly. Next slide. So when I talk to patients, again, I emphasize that how scary the taper is. I emphasize that we'll do it together, that the patient will be involved in the process. I also let the patient know that we'll start wherever they're comfortable. If they want to, for example, taper their fentanyl patch before their oxycodone, that's fine. So giving patients control over which of their opioids they'll taper and to some extent how fast is really important. The other important messages are to let patients know that we can take breaks in the process of the taper and hang out at one dose for a couple of months, but that it's important not to go backwards because then they'll lose all the hard work from the opioid withdrawal. And then probably the most important thing, takeaway message from preparing folks for taper is to just remind them that every time they go down on their dose, their pain will increase. But I'll say to patients, this isn't the pain you'll have to live with. This also isn't a sign of your underlying pain disorder getting worse. This is opioid withdrawal mediated pain. If you can just stick with it, you'll feel better in 2 to 4 weeks. And if you don't feel better in 2 to 4 weeks, we'll slow down the taper. Patients whom I've tapered, have told me that this was the most important thing that I told them, that they should expect to be in more pain the first 2 weeks of lowering the dose, but they would start to feel better at 4 weeks. And again, to emphasize that over the course of the taper, their pain may actually improve. Next slide. And then finally, the O of Bravo stands for other treatments for pain and ways to talk about pain. The next slide. So other ways to talk about pain, obviously, other treatments for pain are non-opioid medications and importantly, non-medication treatments. So these are things like massage, acupuncture, individual and group psychotherapy, physical therapy, any kind of mind-body work. And then within the confines of the visit, it's also important to talk to patients about mindfulness, paying attention in the moment to what they're feeling and trying to make adjustments and breathe and relax, because we all know that anxiety about pain makes pain worse. Opposite action is just encouraging patients to sometimes move their bodies even if it hurts. So hurt doesn't necessarily equal harm. Of course, you want to make sure they're not extending their tissue injury, but unfortunately we've trained sort of a generation of patients to be really fearful and anxious about their pain, so it's important to emphasize that when it's therapeutic, to move their bodies, even if they are experiencing pain. And then finally, radical acceptance is just about accepting the limits of modern medicine and what we can actually do to treat pain, and enlisting patients' own creativity around targeting their pain. Next slide. Sherry continues on buprenorphine 2 years later. She's on 8 milligrams daily. Overall, her pain is actually slightly improved and her function is significantly improved. And now I'm going to turn it over to Ann Burns, who's going to talk about the pharmacy and patient perspective. And this is just a summary of Bravo.
Thank you, Dr. Lemke, and also appreciation to the National Academies of Medicine for the opportunity to provide the patient and caregiver perspective as well as the pharmacist perspective. Next slide, please. I'm going to start by discussing how pharmacists can be leveraged to assist with opioid tapering and pain management. And first of all, pharmacists are highly accessible. So this diagram shows that pharmacists practice in a variety of practice settings, including community pharmacies, ambulatory care clinics, physician office practices, hospitals, and many other settings. Next slide. The types of services that pharmacists can assist with related to opioid tapering include providing opioid dosage conversions for patients who may be switched from one opioid to another as part of the tapering process. In some settings, pharmacists actually deliver the tapering services, making adjustments to medications while they're operating under collaborative practice agreements and working in close collaboration with physicians and other prescribers. Pharmacists have extensive medication expertise that can be used to evaluate all of the patient's therapies. So as it relates to tapering, as the patient is being tapered on the opioid, there is, as mentioned earlier, situations where non-opioid medications are added to the regimen. And pharmacists can help to assess how those medications are working, side effects, and just overall function for the patient, working in a collaborative care approach with others on the team. While this is more common in some settings, like clinic settings, in community practices, it's not as common. And so I just wanted to highlight the importance of sharing of information in these collaborative care models. So if the pharmacist has access to the pain agreement and the tapering plan and the patient's goals of therapy, they can act as an extender to the physician and other members of the team to provide coordinated care as it relates to the taper. And then finally, pharmacists as a core service provide education for patients and their caregivers. And in the case of opioids, this can also include risks, storage and disposal, and in all 50 states, pharmacists can provide or prescribe naloxone. So basically, in the current system, pharmacists are somewhat underutilized as it relates to opioid tapering and pain management, but they have a lot of expertise that could be leveraged if the appropriate mechanisms were in place. Next slide, please. So I'm going to shift gears now and talk about my role as a primary caregiver and living with a patient with chronic pain. And our pain journey started in 2006 with a lower back surgery that resulted in localized chronic pain. 2 additional back surgeries had the pain progress to complex regional pain syndrome that has been managed in the past on opioids, but actually several years ago we were tapered off of opioids to a complex medication regimen. More recently, there is a new injury due to damaged nerve in the neck that has resulted in acute and what is now becoming chronic pain in the right shoulder. Our current team consists of 6 different physicians and a physical therapist. Next slide, please. And I would say that the impact of chronic pain on our daily living is profound. The neuropathic pain is significantly exacerbated by activity, and so we are really limited in the things that we are able to do because of the pain. And then the shoulder pain has further impacted simple daily functions like eating and writing. Our goals, and I really appreciated all 3 speakers and just would like to accentuate all of the messages that they provided, because in some respects I wish that we had had that care at certain points along the way. But our goals currently are to mitigate the pain as much as possible, with a very clear understanding that our pain condition is about coping and not necessarily hoping that the pain will go away. We have very simple short-term goals, and I promise that I didn't collaborate with the speakers on these, but it's basically walking the dog, playing the guitar, being able to play with the grandkids, and whatever travel we would be able to fit in. And we do have experience with opioid tapers, one positive and one not so positive. So I'll be talking about that on the next few slides. Next slide. So data was presented in one of the previous case studies about the percentage of patients on opioids who misuse them and also develop opioid use disorder. And certainly opioids come with significant risks, and they also must be used extremely carefully. From the patient with chronic pain perspective, looking at this from a different lens is that a significant percentage of patients on opioids do not misuse them and do not develop opioid use disorder. So where do we find the fine balance between those patients who could benefit most from opioids at safe levels and maybe those patients for which opioids do not help? I would also say that living with pain in the current opioid environment can be extremely stressful. And we've experienced everything from feeling like the severity of pain was not validated, to stigma, to significant cost outlays due to the fact that many of the treatments are not covered by insurance. Next slide. We also are currently utilizing a variety of different alternative approaches to assist with pain management. And we found that an integrated approach, integrated pain management programs are currently very difficult to find in the healthcare system. So in facing an opioid taper in the context of these challenges, the 3 questions that come to mind for us are, what are the alternatives to help in managing pain? How do I find them? And are they covered through insurance? And there's a recent HHS Interagency Task Force report that does a great job of outlining what some of these alternative treatments are, and they're displayed on the screen, and they were actually covered, some of them earlier. And I'll just say that in our case, we are currently taking advantage of 4 of these different 5 types of treatments, but getting to the point where we have them in our regimen has been incredibly difficult. Next slide. Another consideration is the non-opioid medications. Some of them can come with significant risks and side effects that can also impact function and quality of life. Some of them also take several weeks for onset of action, and some of these medications are also not well covered by insurance plans. The bottles that you see on the screen are the medications that currently comprise our medication regimen focused solely on chronic pain. Next slide. So from the patient and caregiver perspective, The request that we would have, and again, they're accentuating some of the messages in the earlier presentations, is first of all an individualized, patient-centered approach to care that includes compassion. It would also be very helpful because it seems like often in the dialogue we hear this one-size-fits-all of tapering off of opioids, when it might be very helpful to include in the dialogue tapering to safer levels, with a focus on monitoring for improvements or worsening to function and quality of life. It would be incredibly helpful to patients as a part of the tapering process. There were recommendations and referrals for alternative treatment options. And then from a larger perspective, or a more global perspective, we really need evidence-based policies and practice models that foster coordinated, integrated pain management practices. And we severely need research on more effective pain treatments, including the role of opioids in patients with diverse types of chronic pain. Next slide. So just in closing quickly, patients need individualized, patient-centered approaches to tapering that include help with navigating for alternatives when they're needed. And pharmacists have medication expertise and patient access that can be better leveraged in both pain management and opioid tapering. Thank you. And now I'd like to turn it over to Kate Nicholson, who is going to present both the perspectives of her patient experience and also considerations within health policy.
Apologies. I'll start again. I guess I was muted. I thought I unmuted it. For most of my career, I was an attorney and manager in the U.S. Department of Justice's Civil Rights Division, and many of my cases involved discrimination in the receipt of healthcare services, including during the HIV and AIDS crisis. So I'm going to talk a bit about policy because that's my background. But first, I'm also here to provide a patient perspective. My personal story with opioids and pain began in the early 1990s. I was working at my desk one Sunday afternoon, putting the finishing touches on a document due to court, when my back started to burn. The feeling intensified pretty quickly. It was like it felt like acid was eating away at my spine. My muscles cramped, and pretty soon my body seized up on me, and I ended up in a faceplant on the floor. After that, I couldn't sit or stand or walk more than a few feet with a mobility aid for more than the next 15 years. It turned out that it was related to an injury to my spinal nerve plexuses during a surgery, but the symptoms didn't appear until the healing process began and scarring and neuromas formed. I tried lots of different treatments for my pain, interventional treatments, medications, physical and psychological therapies, and I avoided taking opioids for years because I was afraid of them. But after a repeat surgery to address the scarring failed, my doctor suggested that I try them. And opioid therapy, integrated with other treatments, really helped me. I still couldn't sit or stand, but they gave me the capacity to work despite very difficult and limited circumstances. I argued cases from a folding, reclining lawn chair in federal court. I wrote briefs and regulations from bed, and conducted negotiations and supervised other lawyers from a video teleconference screen. And then many, many years later, when improvements in surgical techniques and medical devices led me to improve, I went off of opioids without any difficulty. But one final experience sort of alerted to me to what might be coming in the current environment. I had moved to Colorado, was learning to walk again, and already tapering off of opioids, when I went into the doctor's office, and my doctor announced that she wasn't going to prescribe opioids anymore, and that I wouldn't find anyone else in the area willing to either. And both of those things proved true. A local and very well-respected physician had prescribed to an undercover agent who was posing as a pain patient, and his downfall sent shockwaves through the medical community. I asked her for a taper plan since I was already going down, but she said she was not going to write another prescription. Fortunately for me, I had another option. I had a treatment team back in Washington that gave me an appropriate plan, so I suffered no harm. But again, it gave me a sense of what might be coming. Next slide, please. All of the conversations we've had today are really important because where tapering is indicated, where risks outweigh the benefit for the individual patient, we sorely need evidence-based and scalable protocols. But in the current policy environment, I think it's important to recognize that poorly implemented, non-ideal tapering is occurring, and it's causing desperation and harm. Policies have incentivized abrupt tapers, forced tapers, and patient abandonment. With the pendulum swing of pressures to prescribe and then deprescribe, lots of healthcare workers and patients are caught in the crosshairs. As one of the organizers of this webinar wisely stated, we've gone from a situation in which we incentivized doctors to prescribe opioids and drive down pain scores to incentivizing deprescribing, and that's leading to a lot of confusion and fear of liability. Next slide, please. Since I experienced my own sort of chilling effect, the pressures have been rising. We now have laws and policies overseeing prescribing at every level of the healthcare system. We have state laws. Major pharmacy chains are setting day and dosage limits. Private and public payers are delaying and denying fills. And then there's a fair amount of oversight from the federal government. And this image is a notice that went out to doctors in a couple of jurisdictions based largely on them having one patient over the CDC's recommended MME dosage level. And this is just the tip of the iceberg. There are agencies at the federal, state, and local levels, quality ratings, and other incentives. Next slide, please. So what is the influence or result of these policies? Well, the results have been both positive and negative. In one sense, studies have shown that doctors' behavior and prescribing has changed, and that physicians today are much less likely to begin opioids with an opioid-naive patient, particularly as a first line of treatment. But there has also been a host of unintended consequences. The international watchdog Human Rights Watch issued a report finding that clinicians were tapering patients involuntarily out of fear of liability and even against their best medical judgment. The rationales for this were diverse, everything from law enforcement to a generic fear of liability, to fears from state authority and pressure from payers. Here's a quote from the report from a provider. "I turn away new patients if they are on a high dose. These are folks whose records checked out. They are good citizens, but I can't afford to burn down my life and lose my license." The interagency task force that Anne mentioned, which was assembled from the Comprehensive Addiction and Recovery Act, had similar findings. And very recently, there was a study in JAMA showing that 40% of primary care doctors in Michigan are refusing care for new chronic pain patients using opioids. Let's be clear, this is also happening to people who are appropriately using opioids for an opioid use disorder. The Department of Justice had a recent settlement agreement with a medical practice about that. Next slide, please. I hear from the people and families where things have not gone so well. I receive thousands of emails from complete strangers from all over the country in every walk of life, every day. I hear from patients who are acutely suicidal. I am a pain patient who can no longer get treatment for my pain caused by a spinal cord injury. I do not want to end my life. I want to live. I want to see and hold my grandson. If I cannot get help from someone somewhere, I will not be here next week. I also hear from families who have lost loved ones. My brother passed away. Over the last year, his doctors began to significantly cut down his pain medication. He was truly at the end of his rope. Next slide, please. By far the most frequent thing I hear, though, is people who've lost the ability to function. One woman wrote, "I was independent. Now I have to get my kids to help me because I am bedridden. So I get disability now, and I lost my house." Another wrote, "The tears, grieving, financial loss cannot be described. With my husband bedridden in immense pain, I am so tired now, and we are financially devastated." Next slide, please. The evidence on how widespread this is just beginning to emerge. A lot of it's qualitative at this point, but there is significant evidence that barriers to care and stigma arise from laws and policies. And given the breadth of the regulatory capture, this is a systemic problem. In some cases, the policies themselves have contained a mandate to taper across entire populations. This happened in a recently defeated proposal in Oregon that was really a good idea gone horribly wrong. Oregon was going to cover more multimodal care for pain patients, which is fantastic. But the way they were going to go about that was to force taper every single person on Medicaid with chronic pain. And then over time, it shifted a little bit off of their medication. And there weren't clearly effective protocols or systems in place to do any of that safely. Although virtually all of the pressures in the policy environment have sort of gone in the direction of deprescribing, there was very, very recently a disciplinary action by a state medical board regarding a physician who had tapered a patient to the CDC MME recommendation. The patient became acutely suicidal, and so the doctor dismissed the patient from practice. And she was, in fact, sanctioned for that. Next slide, please. The most recent emerging evidence suggests caution in encouraging tapers as a policy matter. There was a recent study in Vermont of Medicaid beneficiaries at high daily dosages. These were people taking over 120 MME for more than 90 days. And the study found that the median length of time to discontinuation was less than 24 hours, and that almost 50% had an opioid-related hospitalization or emergency room visit. There was also a recent study by Kaiser Permanente in Colorado finding that simply destabilizing the dosage of patients resulted in a 3-fold increased risk of opioid overdose. For those who made it all the way through the taper, the risks went down with discontinuation. Both of these studies concluded that much more research is needed, and the Kaiser study specifically urged policymakers to consider these risks before making further policy on deprescribing. Next slide, please. Over the last year, there's been some stakeholder concern about people being tapered abruptly, forcibly, or abandoned in care. There was a notable stakeholder letter that received some press coverage, and it was signed by people with very different views on whether opioids should be prescribed for chronic pain as an initial matter to an opioid-naive patient. Yet they were all expressing concern about what was happening to patients on long-term opioid therapy. The American Medical Association and other surgical and medical associations have also raised concern about this practice. Next slide, please. So very recently this year, in April, we started to hear from our public health authorities about this. The FDA issued a warning and label change, citing reports of serious harm in patients after abrupt tapers. Those harms included withdrawal symptoms, uncontrolled pain, psychological distress, and suicide. Next slide, please. And the CDC issued a series of 3 clarifications, the primary one by our illustrious moderator and 2 other authors of the CDC guideline. They came out against the strict application of the guideline, especially as to the MME limits by policymakers. And on the right is a letter from Director Redfield clarifying that the dosage guidance in the CDC guideline was not intended to apply to current patients, and that the relevant calculus is whether risks exceed benefits for an individual patient. Next slide, please. We need to exercise caution in absolutist policies on opioids, in blanket applications, and in applying one size to everyone. This is partly how we got into this mess, by giving opioids broadly across all categories of chronic pain. Even in the best voluntary tapering studies, there are exceptions and outliers. Policy needs to leave room for a patient-centered approach and individual treatment plans. Chronic pain is a hugely broad category. Progressive illnesses other than cancer can also cause serious pain, and some people do well on opioid therapy. Palliation and functionality are both valid goals. Being able to work and not just comfort at the late stages of dying. We need to be realistic about the environment. Not everyone receives treatment at Stanford or Michigan. In fact, most people don't. Many alternatives to treat pain remain poorly covered or inaccessible. And finally, we all need to really look at our myopias in making policies. There are, to some degree, dangers in telling stories like mine. And in the case study, I try to be very conscious that my story doesn't apply to everyone, and that I also work in the disability community. So I see a lot of people with very severe conditions. And I think we all need to really take a look at what we do and don't see, because the broader view is really important when we're making policy. Next slide. Rather than pressing tapering as a policy matter, we need the opposite at this point, a prophylactic approach that ensures that patients are protected. One way to do that is to implement the CDC's clarifications. The misapplication has been fast and wide-reaching. We need evidence that the tapering protocols we have are scalable and successful before we incentivize them. And we need to assure the absence of patient harm and have established and tested patient-provider infrastructures for safe monitoring in all aspects of opioid therapy. In conclusion, I would also like to thank the National Academy of Medicine for including people with lived experience, both of pain and caregiving of someone in pain, on this panel. It is enormously important and richly appreciated. And now I will turn things over to Roger Cho, who will facilitate our moderated discussion. Thanks.
Thanks, Kate. We have some questions for the panel. First, I think this will be for Anna, excuse me. You know, oftentimes in clinical practice, we see that patients have persistent difficulty tapering, even when we try to taper slow and when we engage the patient and do all the things to facilitate the taper. They may have persistent withdrawal symptoms, you know, over months or even years, despite doing a slower supported taper. Yet these patients don't meet criteria for DSM-5 opioid use disorder because they don't engage in compulsive behaviors. They're not, you know, using or seeking out opioids that aren't prescribed. They're just having a lot of trouble with the taper. And I'm wondering, how do you approach this patient? Do you have any thoughts or tips?
Yeah, so this is the opioid-dependent patient not meeting criteria for opioid use disorder, who in the risk-benefit analysis does need to further taper opioids. So there are two things you can do in that case. One of them is to go even more slowly. So I appreciate that the question was formed in the context of considering a very slow and patient-centered taper, but it's been impressive to me how slow can be for some patients. Really, you know, even like using compounding pharmacies to get very little amounts, smaller than what comes in the typical pill formulation. The other thing that I and others in this field are finding to be a good pathway is to actually use buprenorphine for this kind of complex opioid-dependent high-risk patient as a harm reduction strategy. So actually, even patients who are not meeting criteria for opioid use disorder, using sublingual buprenorphine formulations, sometimes using a butrans patch to bridge them to sublingual buprenorphine without needing to induce, you know, opioid withdrawal. and then using buprenorphine long-term in these patients to reduce their overall risk, but also optimize their, clinical outcome. The idea is that for some patients, even who are not doing well on opioids and for whom the risk-benefit calculator is still higher on the risk side, we believe that their brains may actually be permanently altered due to chronic opioid exposure and the ensuing neuroadaptation, such that they may actually never be able to get off of opioids because of those brain changes, in which case buprenorphine is a good therapy. It's important to state that it's not FDA approved for opioid dependence, but I think that the label indication should be expanded to include opioid dependence.
Thanks, Anna. I have a question for Chad. So we're seeing more and more patients who present for surgery with either a history of chronic pain or opioid use disorder. Some of these are on opioids already, or they're being treated with medications for opioid use disorder like methadone or buprenorphine or naltrexone. This obviously complicates the picture. How does this impact your approach to managing postoperative pain?
Thanks, Roger. These are complicated situations, and they're situations that I think we can expect to be present for another couple decades as we continue to work through the back end of our current opioid prescribing. In particular, I'll sort of break them down. The chronic opioid user, I think we have seen that preoperative opioid use certainly merits additional postoperative opioid use. However, I would really caution against overly liberal prescribing for the first 3 months, which is what we see for in most cases, surgeon really sort of taking over the prescribing for 30 to 90 days without any coordination with that patient's primary prescriber. And I think for now, given that there really aren't clear data to say how much a person should get above and beyond our existing recommendations for if they're using opioids preoperatively, I think the most important thing you can do is communicate that patient, communicate with their usual prescriber, and make sure their usual prescriber actually knows that they're having surgery and that there's a plan and a coordinated plan for transition back to their normal provider, with the expectation that patient's going to come back to at least that preoperative dose or even lower if the surgery was done to help treat their chronic pain. Buprenorphine and naltrexone and other treatments for opioid use disorder, again, complicated, but we really think this is, again, where surgery, we need to make sure patients are optimized for that surgery, not to withhold care or deny somebody care, but you really need the expertise of an addiction service for that perioperative period, both preoperative optimization, expectation setting, and clear transition back to their usual prescriber. Because in the cases of, say, buprenorphine, simply increasing that patient's buprenorphine as a part of their postoperative care might be the most rational decision. And this has been a point of controversy and, again, a point where there is no data. But as an anesthesiologist, I can also say just simply identifying that person preoperatively, having that communication and a plan in place can really smooth both the preoperative and the postoperative course.
Thanks, Chad. I have a question for Aaron as well. So, there's been discussion about so-called voluntary tapers, yet at least in my experience, patients who truly volunteer to taper are quite uncommon. And you alluded to this a little bit in your talk, but how do you approach situations in which patients remain reluctant to taper, even when you discuss the benefits and harms and try to engage them in the decision? And how is this different from some of the policies that, for example, Kate mentioned that require tapering?
Good question. So I'd say, first of all, we need to have some humility here. There's so much that we do not know about opioids and what they do to people when used long term and how to taper them, that I don't think anyone can put forth a one-size-fits-all solution that's going to work in all circumstances. You know, that applies to the most expert of clinicians, and it definitely applies to policymakers. So, you know, really, I think I strongly believe that we need time to work this out, both with individual patients and overall as as clinicians. We have plenty to learn here. So, you know, a true involuntary taper, forced taper, would be one that was per some kind of policy or protocol. That's just not going to be a good idea. Often there is not really a direct policy or protocol, but maybe a misinterpretation or a concern. There I just would encourage clinicians to make sure they're really treating their patients individually. When I do this, it's true. I rarely have someone who comes to me and says, I want to get off of these things, although that does happen. Usually, a patient does not want to change, and often that is because of, just a lot of concerns about what change would mean. Plus, we've really emphasized some messages that are probably not accurate when we talk about chronic pain and opioids. So there's a lot of work to be done to kind of reframe the idea. But ultimately, if someone is very reluctant to taper or discontinue opioids, what I say is, I simply have no idea whether these medications are helping you or not. I suspect they are not. But there's only one way to know, and that's just, let's just make a small change. Let's start there, and let's reassess, and let's come back together and talk about how it went. I can usually get someone to make that first step with me. And, so they may not have volunteered for that, but I almost always have the experience that Anna talked about, which is that, maybe there's a little worsening in pain or anxiety or sleep disruption initially, but then they go back to where they started, and yet they're on a lower dose. So once you've had some positive experience, then it's easier to keep going down. So really, I think it's just time, giving people some control over it, and just being open to reevaluation. At least that is, to me, the hardest part is just getting started.
Thanks, Erin. That's really helpful. I think in the interest of time, I'd like to open this up to questions from the audience. So, Liz?
Great, thanks, Roger. So our first question is, do any of the physicians on the panel discuss tapering instructions at the time of prescribing to a naive user?
Great. Maybe, Erin, would you be able to talk about that?
Sure. So, if I was starting opioids for more than a couple of days, I think it would be important to mention that even after a few days, they might need to be reduced gradually to avoid withdrawal symptoms. I do generally, this is not just for opioids, but all medications that require tapering. I think it's really important to give that information up front. And it's amazing how little information is out there about tapering. And even many physicians aren't very knowledgeable about it. So just going back to the prior talk about pharmacists' role, sometimes, even if your prescribing clinician can't advise, a pharmacist may be really helpful.
Thanks, Erin. Yeah, and just thinking about, Chad mentioned this in his talk, but I think a lot of clinicians are actually not aware that tolerance can develop very quickly. I think people assume that if somebody's given a 5 or 10 day course of opioids that they can be taken off. And, I have patients certainly who will tell me they're feeling terrible, they're having sweats, they feel awful, and it's probably that they're experiencing some withdrawal, even though it's really just been short-term opioid use. Do we have another question, Liz?
Yes. can you discuss characteristics of opioid use duration in patients who do and do not do well in opioid tapering? For example, daily opioid use for many years would seem to portend poor taper outcomes. Is this true?
Yeah, Anna, would you be able to address that?
Sure. You know, I think Erin spoke to this briefly at the end of her slide, that she's had patients on long-term opioid therapy get off and have no problem. And that's been my experience too, that it's pretty unpredictable, that there are patients who you would think based on dose and duration would really struggle, who don't struggle that much, and then patients on low doses, well below the CDC MMEs, no history of addiction or complex psychiatric history, who really struggle to get off. So it's kind of, I would say it's basically unpredictable.
Yeah, there's probably multiple components. There's probably some genetic components that we don't fully understand, plus, you know, various psychological and medical factors that can impact, you know, how quickly or how well somebody's able to tolerate the taper. Thanks, Anna. Do we have another question, Liz?
Yes. What do the presenters recommend be done if the patient tests positive for illicit drugs? Would they do anything other than not fill the prescription?
Yeah, so I don't want to keep calling on Anna and Erin. Maybe Anne, is this something that you're able to help address? You might be on mute.
This is Anna, I can just say, you know, I think one of the main messages of this webinar is that what is happening is that when patients are testing positive for illicit drugs, sometimes the providers are, you know, scared and essentially fire the patient from their practice for that reason. And so I think, you know, we're all really in strong agreement that is not something that we want to be happening, that what you want to do when you find that out is just add substance use problems to the problem list and include that in, you know, the broader sort of risk-benefit analysis of opioid prescribing. If the other substance is an opioid, in addition to the one you're prescribing, I think that would certainly make you quickly move toward diagnosing an opioid addiction or opioid use disorder and then getting the patient treatment for their opioid use disorder. But kind of reflexive, like, oh, this person tested positive for coke or meth, you know, I can't treat them, is, I mean, I have a lot of compassion for that reaction, because when I graduated from medical school, I didn't know anything about how to treat addiction. But that's what we don't want to happen. What you want to do is add it to your problem list, and then you know, work with people either in your practice or other consultants to develop a team to address that while you continue to address the pain condition.
This is Erin, and I agree completely with what Anna said. I just want to also chime in, because I did have that slide where I talked about entirely physician-driven unilateral decisions to discontinue opioids. I was not referring to someone who was taking their opioids in that case. So, you know, I think I said, you just would not re-prescribe it. That's only if you're very confident the person is not taking the opioids, as in kind of a diversion situation. You know, if someone is using illicit drugs and using opioids, they still need to have opioids tapered. It may be a more rapid taper, more driven by you as the prescriber, but you know, you cannot skip that taper step and just cut them off. That's not going to result in an improved health outcome. Really, the important thing here is you want good health outcomes.
Right, and those patients actually are some of the patients who would benefit the most, actually, from additional treatments for substance use disorder, etc.
Roger?
Oh, yes, go ahead.
Sorry, this is Anne. I accidentally got disconnected. Just one thing to add that's a little bit of a variation, but something that we experienced as part of a taper, and that is in regard to urine drug testing and making sure that the providers understand the tests. And we actually were accused of an opioid, of taking an opioid that happened to be a metabolite of the opioid that was in the regimen. So I just thought I'd throw that out there. It's a little bit of a variation on the illicit drug question, which is a very important one and was answered very well.
Thanks, Anne. Yes, interpreting urine drug tests can be quite complicated. Liz, is there another question? Maybe one more?
Yes, thanks. What can a patient do when they want to taper and have no guidance from their prescriber? Where do they turn?
Kate, would you be able to address that?
I can try. I mean, I think that if they want to taper, they should certainly talk to their prescribing physician. I know that most prescribing physicians, I think in pain management, are well equipped to help with a taper protocol, but certainly Travis Reeder's situation, which Chad mentioned earlier, where he had a series of 6 surgeries and was on opioids for a longer period of time. One of his most difficult, one of the problems he pointed out that was most difficult was that nobody took responsibility for helping him with the taper, and he is a bioethicist at Johns Hopkins and a fairly privileged patient, and still couldn't find someone who was willing to assist. So I do think there are real holes out there, but at least in pain management, it's been my experience and in working with patients that most physicians are willing to assist with a taper. And there are voluntary studies. There are studies going on right now in California and some other states that are willing to take people who are on opioids and aren't able to find assistance. I know one is being run by Beth Darnell.
Yes, great. Thanks, Kate. Liz, do we have time for one more, or should we?
Yeah, maybe one more question would be great. Here it is. I have found insurance coverage to be a barrier to tapering. Most pharmacy benefit managers, pharmacy benefits are not willing to cover the varying doses and pill counts required for tapering. Has this been your experience, and what can be done about it?
Thanks. Yeah, Anna or Aaron, do you have thoughts about that?
Well, I mean, I experienced pharmacy benefits managers to be obstructionistic for pretty much anything that I want to do. So, yeah, I mean, I can certainly sympathize with them. I guess I haven't in general found that the tapering kind of elicits any more paperwork or, arguing for medical justification as other things that I do.
Yeah, I mean, this is Roger. I mean, sometimes the changing in doses seems to cause some problems. It's like a new prescription or something, and they will request additional information for prior authorization, or they'll say the dose is too high even though you're going down on the dose, that kind of thing, which can obviously be frustrating. But usually we're able to work through those issues, as long as we're able to explain that we are engaging in the taper. There are some policies to try to avoid prior authorization requirements for treatments for opioid use disorder and to eliminate time limits on those, which would be a step in the right direction as well. Great. Well, I think we're to the end here, Liz.
Yes, thank you. We are at 4:30 now, I believe. So I'd like to conclude the webinar by extending our special thanks to the webinar speakers and to all of the attendees for participating. If you have any remaining questions or comments, please email us at opioidcollaborative@nas.edu, and we will do our best to get back to you promptly. A link to the webinar recording as well as a copy of the slides will be posted on our website within the next week or so. So thank you all for joining us today, and have a great rest of your day. Thank you.
Thank you. Bye-bye.